Yes.
Good afternoon and welcome to one and all. I am Sneha from Clarinet, the designation session assigned for the Seamless Experience. Clarinet is very proud to be a digital partner for the event organized by the Karnataka chapter of the Indian Society of Assisted Reproduction. Welcome to all the webinar on KISAR Journal Club discussion. So without further delay, I want to take this handover to Dr. Santosh Gupta, ma'am. Over to you, ma'am. Kindly proceed for your talk. Thank you.
Thank you very much. So on the behalf of KISAR team, I welcome you all the audience, participants and presenters. It gives me great pleasure and pride to start the first general club meeting of the new KISAR team. I would invite Dr. Nivedita if she is present. Dr. Nivedita?
She's around here.
Yes, yes.
I would invite our KISAR president, Dr. Nivedita, to take over session from here.
The plan. Thank you, Santosh. Thank you. And of course, it gives us great pleasure to start this, take this initiative. This has always been very popular. Me to introduce Ashwini. Ashwini is doing the first journal club, and she's always been a very academic and dynamic person. She's also the secretary. And Ashwini, why don't you take over? You introduce your speakers, and we have a very interesting topic today. So I'm sure we'll take home some great messages today.
Thank you, Dr. Nevi. Right, so welcome all. It's such a happy and joyous moment that so many of you have joined for an academic discussion. So without much ado, let's jump into it straight. Don't want to waste anybody's time. Dr. Jayashree is a fellowship student at Aspire, and she's pursuing fellowship and will be exam going now. And she has picked up a very interesting and a very nice topic for discussion today, which is PPOS protocol. Co-moderating this meta-analysis and systematic review along with me is Dr. Narmata, who is another senior consultant at Aspire Faculty for the past 7 years or so. Welcome, Dr. Narmata. Welcome, Dr. Jayashree. I would urge Dr. Jayashree to share her screen and start off the presentation. And as we go through it, then we'll have discussions. Feel free to actually put up in the chat box any points that you want to discuss or any queries that you guys want to ask, which will be taken up either in the middle or at the end of the presentation. Thank you.
Thank you, ma'am.
So is my slide visible, ma'am?
Yes, it is visible. I would also request all participants to mute their audio, please, till the presentation is midway, at least. Thank you. Yes, Dr. Jayashree, you can take it forward.
The slides are not moving, so
yeah.
I'm opening it in a different screen. This okay, okay, go back. Like this. Okay.
It's being recorded.
Yes.
Hope my slides are visible, ma'am.
Yeah, they are visible, Dr. Jayashree.
Okay. Okay, ma'am, I'll start now. So good afternoon, respected seniors and my fellow colleagues. So I'm Dr. Jayashree Subramaniam. I'm currently doing fellowship in reproductive medicine in Aspire Fertility Center. First of all, I want to thank Dr. Ashwini ma'am for giving me this opportunity on this big platform. So yeah, we will go ahead with the journal presentation. Sorry, slides are. Yeah. So the journal topic which was given to me is effectiveness of progesterone primed ovarian stimulation in assisted reproductive technology, a systematic review and meta-analysis. This was published in Archives of Gynecology and Obstetrics, and it was published in January 2021. So this one, how to... So PPOS is a new ovarian stimulation protocol that has been used over the last decade to enhance reproductive function. PPOS was proposed by the Yanping Guang MD group in 2015. It prevents the activation and transmission phases of estradiol-induced LH surges and thus serves as an alternative to conventional treatment with GnRH analogs. Oral administration of exogenous progesterone such as medroxyprogesterone acetate and dydrogesterone beginning in the early follicular phase is used with gonadotropin during controlled ovarian stimulation. Medroxyprogesterone acetate produces competent oocytes and embryos and achieves comparable pregnancy outcomes to those of GnRH antagonist protocols as well as short-term protocols and stimulation protocols. There are many clinical studies on PPOS protocol used in infertile women and in women who have normal ovarian function, PCOS, poor ovarian response, who are of advanced maternal age, having endometriosis and donated oocytes. The reported findings are variable. Some studies have shown better live birth outcomes, while others showed no difference. PPOS protocol may be cost-effective compared with GnRH antagonist in planned freeze-only cycles such as pre-implantation genetic testing or fertility preservation. Compared with control ovarian stimulation, the PPOS protocol neither compromises neonatal outcomes of IVF newborns nor increases the prevalence of congenital malformations. PPOS protocols may offer a variety of options such as medroxyprogesterone acetate, dydrogesterone, or etrogestone. In PPOS protocols, there are options. These options are sufficient enough to prevent an untimely LH rise. Dydrogesterone administration in PPOS protocols produces a comparable number of top quality embryos and pregnancy outcomes compared with medroxyprogesterone acetate. Further randomized control trials are needed to confirm this conclusion. So the purpose of the systematic review was to investigate whether PPOS for the treatment of infertile patients achieved pregnancy outcomes that were the same as or better than those of conventional protocols. So this is the first meta-analysis to examine the effect of the PPOS protocol in ART. So the methods used. Criteria for considering studies for this review. It was pairwise and meta-analysis. Types of studies. Intervention studies in the form of RCTs and non-RCTs that compared PPOS to other protocols. Types of participants. Participants suffering from infertility. Types of interventions. Study intervention was PPOS. And the control interventions included the GnRH antagonist protocol as well as short-term protocol and mild stimulation protocol. So types of outcome measures. The primary outcomes they had taken in the study were clinical pregnancy rate, live birth rate, incidence of OHSS. Secondary outcomes, duration of stimulation, dose of gonadotropin for injection, progestin values on trigger day, number of retrieved oocytes, number of M2 oocytes, number of obtained embryos, total cycle cancellation rate, and endometrial thickness. So data collection and analysis. So selection of studies, titles and abstracts of articles were screened by 2 independent researchers, those were the authors, to be included or excluded. A third author would evaluate records when there was any unsolvable disagreement. So data were extracted by one reviewer and checked by a second one. So the data were study design, methods, setting and time period, information about the participants and dropouts, interventions and outcomes. So search methods for identification of studies. The study is based on based by Prisma guidelines, and the electronic databases used were Medline, Embase, and the Cochrane Library from 2010 to 13th March 2020. Intervention studies, prospective control study, retrospective cohort study, NRCTs with comparison groups, and RCTs. Inventions of the control group. So the inventions were like discussed before: short-term protocol, GNRH antagonist protocol, and mild stimulation protocols. So self-control study, books, conferences, review articles, editorial, notes, thesis, case series, letters, posters, and case reports, and also unreliable extracted data, overlap data sets, and paragraphs of only abstract were excluded in the study. So assessment of risk bias. So the Cochrane collaboration tools were used to assess the risk of bias in RCTs. So they had rated the quality as such, low risk, unclear risk, or high risk in RCTs. And Newcastle Ottawa scale was used to assess the quality of NRCTs in this meta-analysis. So it was rated as like high quality studies. It is like from 0 to 9 stars. If it is more than 7 stars, means it's high quality. Medium quality means between 4 and 6 stars. And poor qualities means it would be less than 4 stars. So this is that risk of bias assessment chart. Data synthesis. All data were entered into the analysis system, Review Manager version 5.2. They use the risk ratio and 95% confidence intervals for variables with dichotomous data for RCTs and odds ratio for non-RCTs. For these variables, the weighted summary risk ratio was calculated using the Mantel-Hansel method. For continuous data, the mean difference was calculated and corrected according to the sample bias. They constructed summary of findings tables using Grade Pro. So subgroup analysis, Higgins I-square values were used for this. Usually Higgins I-square is to assess, they used it to assess a statistical heterogeneity between studies. So values of I-square less than 25% indicates low heterogeneity. But in this study, I-square were more than 70%, and it is not suited for combined analysis. So they had performed a subgroup analysis. So our subgroup analysis was for clinical pregnancy rate, live birth rate, and dose of sex hormones for injection, considering the different types of sex hormones, that is a recombinant FSH subgroup or HMG subgroup, according to clinical experience. So now coming to the results. This is hiding.
Dr. Joshi, you're not audible.
Yeah, ma'am.
Okay.
Am I audible, ma'am?
Yes, yes. Results, yeah.
Okay. A small part of my screen is hiding behind. So that's fine.
Okay.
So, yeah.
Just move the Zoom
Sorry.
window to one corner. That will be easier.
Okay. Good. Yeah. Thanks, ma'am. Okay. So yeah, so out of 117 of records identified through database searching, after removing duplicates and relevant records, they had come down to 11 studies. Ma'am, can you hear me?
Yes, yes. Yeah, please go ahead.
So they had come down to 11 studies, including 5 RCTs, and remaining were 6 non-RCTs. So these are the studies which they had taken for the meta-analysis. So in this 5 RCTs, and the remaining are non-RCTs, including retrospective cohort study and prospective non-randomized control study. So coming to primary outcomes, clinical pregnancy rate. So 5 RCTs showed that the clinical pregnancy rate with the PPOS protocol was not different from that with the control group. And 5 RCTs did not show any significant difference in the clinical pregnancy rate between these two groups. But it is not statistically a significant difference. A subgroup analysis, 2 RCTs in the recombinant FSH subgroup showed that the PPOS protocol had a lower preclinical pregnancy rate than the control group. And it is statistically significant. And 3 RCTs show that in the HMG group, subgroup, the PPOS protocol led to a higher clinical pregnancy rate than the control group. This is also statistically significant.
Okay, let me just interrupt here. That slide is important, I think. So according to the RCTs and the NRCTs, there is no difference in the clinical pregnancy rate between PPOS and any other protocol for that matter. And the other protocols they used as comparison was ANTAG and what were the other protocols that they had used for comparison? ANTAG, minimal stimulation and
Mid-mild stimulation and short-term stimulation.
short-term antagonist protocol. So, so in these comparisons, there was no difference in the clinical pregnancy rate. But in subgroup analysis, if they have used in 2 RCTs, they interpreted that if they are used recombinant FSH, it showed that PPOS had a low pregnancy rate. Which means to say in a PPOS protocol, if we are using recombinant FSH, the pregnancy rates tends to be low. Is my understanding correct?
Yes, ma'am.
Right. Yeah. I would also share our experience here. We had also tried, we have been trying PPOS for almost more than 2 years now. In the initial few cases, when we were trying PPOS first with donors, we found that when we were using only RFSH, the response to stimulation was extremely low. I still remember that we had used Gonalef 225 for a donor and had started her on a PPOS with Meprate, and we landed up having no response at the end of 6 days of injections. So it means to show that, adding HMG for stimulation is very critical in PPOS protocols, right? And if in case HMG is added, the pregnancy rate also seems to be at a higher rate, according to a randomized control trial, 3 RCTs, right? Jayashree, the last one?
Yes, ma'am. Yes.
Can I interrupt here?
How much is the difference? They haven't given, they have just showed a significant. Yeah, Dr. Nivi?
No, I was just wondering if they have this RCTs, this is which protocol are they talking about? PPOS is compared to which protocol? Yeah, is it the protocol or is it the short term? They haven't mentioned mild stimulation. Which protocol are they comparing here? They're saying
RCT had quoted as 3 RCTs, but they hadn't these RCTs using which protocol they didn't mention.
And they always say that the PPOS protocol, what I notice is the dose of stimulation, the response, all that is similar as what they say, right?
Yes. Correct. That's coming in the next slide, I think. Jayashree, also, can you briefly describe how a PPOS protocol is done for the benefit of everybody who's listening?
Yeah. So the patients, we are in our center, we are giving Meprate tablet. So it is 10 mg. We are breaking into 2. That is like 5 mg we are giving morning and 1 5 mg in the night. From day 2 or day 3 of when we are stimulating the patients with gonadotropin, the same day we are starting this Meprate tablet. Still the trigger injection, that is like throughout the follicular phase. And the gonadotrophins also would be started. So we were using a recombinant FSH plus HMG. So like that, according to the patient's this thing, we will be tailoring gonadotrophin injections, and we will be continuing that till the time of trigger injection. And when the follicles reaches, we will be monitoring the follicles with ultrasound. When it detects the follicles more than 18 mm, at least 3 follicles, then we will give the trigger. And after 36 hours of the trigger, we will be doing the ovum pickup.
Correct. So basically, you start Meprate at 5 mg twice a day, starting along with your gonadotropin dose whenever you do that. And then once the monitoring has for any other stimulation protocol, and once you feel that the follicles are ready, you trigger. Is there any difference between the triggers, or it's a choice between analog and Meprate and HCG?
Actually, most of the time, what we had used is a GnRH agonist only. Sometimes GnRH agonist with low dose HCG or like HCG also, like dual trigger also we had tried.
Okay. All right.
I have one more question here, because here usually in NTAG protocol we call on day 6 to start antagonist. That is our main agenda. So going forward, do you feel that it will reduce the monitoring days also? We can call them
Yes.
later as well,
Yes,
because
yes,
there
that's
is
an
no change
advantage.
in protocol.
Yeah, that's an advantage. But because we were doing the study, we here Dr. Jayashree has done a thesis. I think I've asked her to present that also at the end of the presentation. She used to call on day 2, and we had the protocol wherein we used to call on day 6 when we used to start ANTAG for comparison of LH between the two. So going forward, now that it is established PPOS is as good as ANTAG, I think the day 6 visit may not be essential. Even if you call on day 7 or day 8, should be fine, depending on how the baseline follicle is. If the baseline follicle, all of them are less than 1 centimeter, it's a choice whether you want to call on day 7, day 8, or however it is.
And trigger also could be GnRH analog, because this is
Yes,
all
yes.
going to be turned into all freeze. But we can
Yes.
use HCG if we want. But
If we want, yeah. If suppose there has been a bad experience with that particular patient and analog has not given good number of oocytes or follicle or egg retrieval per follicle has been lesser, we can always choose to add HCG2.
I have a doubt here. In Jayashree's thesis, you compared LH levels on the baseline LH
She's
with the
presenting, yeah. She's presenting it at the end, maybe. We can ask her again. Right, Dr. Jay, she can move forward.
Okay. So this is the forest plot study for the clinical pregnancy rate and the subgroup for between recombinant FSH and HMG. So the next comes live birth rate. So the live birth rates were not different between the groups in 3 RCTs, and it is not sort of statistically significant. Results of one NRCT showed that there was no difference between the two groups. OHSS, only 2 RCTs described the incidence of OHSS, and the research showed that the PPOS protocol had a lower rate, and it is statistically significant. So this is the forest plot study. So OHSS is favoring PPOS here. So next slide. Secondary outcomes. So duration of stimulation day. Data from both RCTs and non-randomized trials showed that the duration of stimulation between the two groups was nearly the same. Dose for gonadotropin. So they had performed pre-planned subgroup analysis for this dose of gonadotropin for 2 different kinds of gonadotropin. So 2 RCTs in the recombinant FSH subgroup showed that the mean difference in dose for PPOS in the recombinant FSH subgroup was 55.1 higher. And only 1 RCT showed mean difference in dose of the PPOS protocol was 121.3 lower in the HMG group. So these differences were not statistically significant. And non-randomized control trials showed that the mean difference in the subgroup of recombinant FSH was 116.47 lower. And NRCTs in the HMG subgroup showed that the mean difference for the PPOS protocol was 440.08 higher. So it is statistically significant. So this is the forest plot study. So progestin values on trigger day. Data from both RCTs and NRCTs show that the progestins were nearly the same, and a number of retrieved oocytes were also nearly the same from when seen for data from both.
Yeah, just one interesting point I also came across in the whole monitoring that they have done is that they preferred not to measure LH anywhere. They rather measured the progesterone levels. Right? There was no comparison.
And that is also interesting. We are giving
Correct.
progesterone, but progesterone is coming normal. Other
Yes.
protocol, we
So
are not giving progesterone.
That's a different progesterone. This is
This
a
means to
natural.
say that medroxyprogesterone is not detected by our conventional progesterone assays. It is only the natural progesterone that gets picked up, and yeah. Right. Okay, Dr. Jayashree, go forward. Yeah.
Yeah. So coming to number of retrieved oocytes, the data from both RCTs and NRCTs were showing that the number of retrieved oocytes was nearly the same in both groups. And number of M2 oocytes, if we see data from either RCTs or NRCTs, the M2 oocytes were in both groups was nearly the same. But all were like showing the statistically not significant difference. This is the forest plot study. So, and number of obtained embryos, only the 5 RCTs had the date of the number of obtained embryos, and the results showed that the EPIPOS protocol had more obtained embryos, and statistically it is significant. And total cycle cancellation data from both RCTs and non-RCTs showed that there were no significant difference between the groups. And endometrial thickness, data from RCTs showed that the endometrium was thicker with the PPOS protocol than with the control protocol, and it is statistically significant. And another data from NRCT was showing surprisingly endometrium was thinner with the PPOS protocol than with the control group, but it is showing non-significant, non-statistically significant thing. But in the upcoming slides also, they had I had mentioned that the study has told this evidence is low quality evidence as per grade pro.
Yeah, and this is one interesting point where they're saying that in PPOS protocol, wherein you're starting progesterone from day 2 itself. I was expecting that the endometrium will be very thin. That is what would be the finding, but they found that the endometrium was much thicker in PPOS than in the control group. This is a little difficult to explain actually. Right, you can move forward.
Yes. This is the first plot study for number of obtained embryos and also total cycle cancellation, endometrial thickness. So discussion. So PPOS protocol had more obtained embryos and a thicker endometrium than the control protocol, and with a lower rate of OHSs. And there were no significant differences between the two groups for live birth rate, duration of stimulation, progestin values on trigger day, number of retrieved oocytes, number of M2 oocytes, and total cycle cancellation rates. So if you see when patients recombinant FSH when given to patients, clinical pregnancy rate was lower in the PPOS group than in the control group. So it is statistically significant. And 3 RCTs showed HMG subgroup CPR was higher in the PPOS group than in the control group. It is near statistical significance. And results of the RCT of the recombinant FSH HMG subgroups, no significant difference in the dose of recombinant FSH HMG between the two groups. Only NRCTs in the HMG subgroup, dose of HMG in the PPOS protocol was higher. And RCTs PPOS protocol had a thicker endometrium and the quality of evidence was high with a significant difference. NRCTs endometrium was thinner with the PPOS protocol and the quality of evidence was low with no significant difference. So from this meta-analysis, they conclude that there is no difference in the live birth rate. And in the subgroup analysis, the HMG subgroup had a better clinical pregnancy rate, while the recombinant FSH group had a lower clinical pregnancy rate than the control group. So it may be suggested to choose HMG for control ovarian stimulation in the PPOS protocol. So strength of the study. So strict methodology guided by PRISMA guidelines would be the strength of the study, and quality of the RCTs was evaluated using the Cochrane handbook method, and quality of non-randomized control trial was evaluated using the Newcastle-Ottawa scale, and the graded the certainty of the evidence for critical outcomes by grade pro. These were all the strength of the study. And limitation, only 5 RCTs were included in this meta-analysis. The outcomes of our NRCT by grade pro were quite low. And 6 of the 11 records included were from China. That is more than half of the studies are from one location only, that is China. So there is no conflict of interest for the study. And finally, they concluded PPOS protocol produces more obtained embryos, a thicker endometrium than the control group, with a lower rate of OHSs, equal clinical pregnancy rate, live birth rate, duration of stimulation, progestin value on trigger day, number of retrieved oocytes, number of M2 oocytes, and total cycle cancellation rate. These were all equal between these two groups. And in the subgroup analysis, the HMG subgroup had a better clinical pregnancy rate, while the recombinant FSH group had a lower clinical pregnancy rate. And it may be suggested to choose HMG for control ovarian stimulation in the PPOS protocol. More RCTs should be performed to evaluate the best ones for respective infertile patients. So this is the last slide for the meta-analysis study. I want to add some more slides, like more similar to the study I had also done as part of my thesis in our center study, that is comparing the performance of progestin primed ovarian stimulation protocol and the flexible antagonist protocol in avoiding premature LH surge and outcomes of IVF cycle. So aim of my study was the same, like to compare the PPOS protocol with the antagonist protocol in avoiding premature LH surge and outcomes of IVF cycle. So I had included premature LH surge, duration of stimulation days, total dose of gonadotrophins, duration of GnRH antagonist, or if used medroxyprogesterone acetate, number of oocytes retrieved, number of M2 oocytes, that is maturity rate, fertilization rate, cleavage rate, blastocyst rate, OHSS in my for my primary outcome. And for secondary outcome, cumulative positive pregnancy test and rate and cumulative clinical pregnancy rate. So materials and methods, it was done between October 2022 to July 2023. It is a 10 months duration study. And inclusion criteria are all patients who are undergoing IVF ICSI between the age of 20 and 40 years. And exclusion criteria, age above 40 years, hypo patients, pituitary disorder, documented ovarian failure, severe acquired uterine malformations like Asherman syndrome, abnormal results on parental karyotyping, presence of functional ovarian cyst. So at the start of my study, I assumed the population size is 17. The study would require a sample size of 60 for each group, 30, to achieve a power of 80% of 95, significance of 5%. So, but like now I had taken 40-40, that is total study population of my study is 80. So 40 in PPOS and 40 in flexible antagonist protocol group. So statistical analysis, it was performed by the SPSS program for Windows, version 20.0. And for all the continuous variables like age, BMI, duration of infertility, etc., independent T test was used. And all the for all the categorical variables like age categories, PPT, CPR, that is positive pregnancy test, clinical pregnancy rate, were compared between PPOS and antagonist protocol using chi-square test. And all the data was analyzed using the statistical package for the social sciences for Windows, version 20.0, IBM Chicago. For all statistical tests, a p-value less than 0.05 was taken to indicate a significant difference. So age and BMI, it was almost the same between PPOS and ANTAC group in my study. And LH levels in PPOS and ANTAC, here, like for LH and all in PPOS and ANTAC, if we take PPOS group, we used to measure the LH levels, also E2 and P4 on day 2, and also on day 6 of stimulation and on day of trigger. So this is the table which is shown here. And
yeah, in fact,
also in ANTAC protocol, one like LH E2 P4, we would be calculating on day 2 of stimulation. It's like day 1 or day 2 of simulation, and the LH to P4 would be measured on like when the follicles reaches 14. That time we will be taking the LH to P4 measurements in ANTAC protocol, and on trigger again LH to P4 would be checked in ANTAC group.
So if I can interrupt here, basically, we had measured LH and P4 on day 2, day 6, and on the day of trigger. And we found that we had missed some LH surges in ANTAC. I mean, LH surge had almost started when we started the ANTAC. This is very much in sync with the flexible protocol, because sometimes you tend to miss out on a silent surge. If you see the range of LH, on day 6, you see that I think a patient reached almost at 19. And then we gave a double ANTAC and then controlled it and went ahead and still did the pickup with a good outcome. So PPOS is almost matching with LH as far as suppression, as matching with ANTAC as far as suppression of LH is concerned, and better than ANTAC, it looks like. Obviously, for the fact that there is a strong suppression of the pituitary here. What about progesterone? It's in the next slide.
Yes, ma'am. So about this LH levels, can I explain that?
Yes, please. Yeah.
So LH on day 2 is higher in PPOS group, but with a p-value of 0.557, and LH on day 6 is higher in anti group with a p-value of 0.081, and LH on trigger is higher in PPOS with a p-value of 0.745. And next comes estradiol levels. So yeah, here if you see E2 on day 2 is higher in anti group, 0.144 as p-value, and E2 on day 6 it is higher in anti group with a p-value of 0.348, and E2 on trigger is higher in PPOS group with a p-value of 0.954.
But none of them are significant, right?
None of
Yeah.
like all
P values are
LH
insignificant. Yeah, they're not significant between the two. Yeah.
Yes, yes. Next comes progesterone. So here, progesterone on day 2 is higher in PPOS group with a p-value of 0.26, non-significant, and P4
No.
on day 6. Yeah, ma'am.
No, if it is not significant, that means it has no relevance, even if it's slightly higher. All
Yes,
the
ma'am.
three p values were not significant, right? Or was there
Yes.
any significance? No, all three
No, no.
values were it. Yeah.
No,
So it was matchable between the two groups. P4 values
Yes.
were also matchable. Okay.
Yeah, it is comparable.
Yes.
And in fact, P4 is more control in the PPOS group rather than
PPOS.
NTEC group.
Yes.
Even if
Yes, Dr. Santosh. Yes. Right. Next
So,
slide.
number of stimulation days. If we compare number of stimulation day between PPOS and ANTAC, it was showing higher in PPOS group, but it is not statistically significant. So if you see the mean also, it is not that much big difference you can see here. So here and here.
Okay.
And yeah, next gonadotropin dose. Comparison, comparing the two groups, the GTN total dose is higher in anti group with a p-value of 0.46, which is showing non-significant only. Much of a difference, but I can say 100 to 200 difference between the PPOS and anti.
Yeah. So we should not be mentioning it as higher. It is comparable between the two groups is what we would mention it, because the p-value is insignificant.
Okay.
P-value shows that it is insignificant difference between the two, which means GTN dose is comparable between the two groups.
Okay.
Right.
So LH surge suppression, if you see, none of the cases had premature LH surge in both the groups. So coming to embryology data, if we see maturity rate, we all know that maturity rate is number of M2 oocytes by total number of retrieved oocytes into 100. So yeah, like that maturity rate, fertilization rate, cleavage rate, blastocyst rate, utilization rate I had tabulated here. So yeah. So coming to maturity rate, if you see between the two groups, it is statistically non-significant only. So it is comparable between PPOS and ANTAC.
This was a surprising point that came up to me, having a M2 rate of 57 and 56. It looks like our stimulation has to be refined a little more. I would have wanted the M2 rate to be at least 80 or 90%. Dr. Nivedita and Dr. Santosh, what do you say? M2 rate,
no,
benchmark?
usually in general, it should be around if not 80, 90, I think 70 to 80 is the acceptable thing.
Yeah. I think there's scope for improvement with us
Can
here.
I add on?
Yes.
I had a doubt because in your study, she's not mentioned what is the kind of gonadotropin she's used. And in the previous paper, which she presented, we know that whether you're using recombinant recombinant FSH or HMG makes a difference. Maybe that would have actually.
Yeah, so as I mentioned before,
difference.
Navya, we started first with recombinant FSH. I mean, when we started PPOS, we started 1 or 2 cases with RFSH and Mepred. And we were really disappointed for the fact that there were times when 5 days of gonadotropins and there was no response. So from then on, we searched the literature a little more, and then we understood that HMG has to be added in PPOS. So we never did anything with the only recombinant. It has always been recombinant plus HMG. So all the cases that are done here, all the cases that are done here is RFSH plus HMG in an equal 50-50 dose. Yeah.
Okay.
Thank you for
and
the
these
question.
are all self cycles.
These are there are donor cycles also. There are donor stimulations also, and there are
Okay. I think we'll proceed.
Yeah. So next coming as the fertilization rate, and it is the fertilization rate is higher in ANTAC group with a p-value of 0.233. So it is
1.202, so it is not different.
yes.
Yeah.
It's similar.
The next comes cleavage rate. So between the two groups, it is similar only because this p-value is non-significant. Difference it is showing, that is 91, 94. 91 in PPOS, 94 in ANTAC. Blastocyst rate also is almost similar, comparable between both the groups. 54, 54 it is. Almost nearly the same. And utilization rate, so between the two groups, the utilization rate also it is comparable with a non-significant statistical difference of 0.921. And coming to the cost difference between PPOS and ANTAC. So normally we know only Meprate tablet or each strip it is like 62 rupees, and injection cetrotide almost 2624 each injection. So if we see the one second. Yeah. So there is a the cost effectiveness of PPOS is shown like better, and the p-value also is statistically significant. It is less than 0.001.
This was the only significant difference between the two
Yes,
subgroups. Right. All, I mean, primary outcomes were similar. Secondary outcomes, I think Dr. Jayashree is still working on that, the clinical pregnancy rate and the ongoing pregnancy rate. As far as I understand, it is coming somewhere, pregnancy rate is coming somewhere around 70%, and ongoing pregnancy rate is coming somewhere at 57% or so, which is again matching between the two. So looks like between PPOS and ANTAC protocol, there's literally no difference except for the fact that the cost of PPOS is very, very low. And what we need to keep in mind is that no question of transfer at all. And adding HMG is extremely important in PPOS protocol because it is shown by the meta-analysis. And we have also learned from our experience that recombinant FSH alone in a PPOS is not a great idea. And of course, we save money with the PPOS. Any questions that we can take here?
I have one question. One is I think we all should congratulate your entire team. You not only presented a meta-analysis, but it was wonderful to know what exactly happens through your thesis. So I think for all of us, learning through your center thesis is quite important. So that is number one. Number two, what comes in my mind is progesterone prime protocols looks wonderful. It is as far as the antagonist protocol, but there are two things we have to see is we are sort of implementing on ourselves as a all freeze protocol if we are using progesterone prime, and the cost of freezing and thawing is very high. Cost of freezing and thawing, whether in all centers we know how it is. So what do you feel about that? Are we justifying in saving some and spending more later? That is number one question. So what was your experience? And another is in Cochrane, that meta-analysis where your Dr. Jayashree has presented, there also some cost discussions were done or not done. So
Dr. Jayashree, want to take the questions and give your comments on that?
About the second question, ma'am, regarding cost, they hadn't mentioned anywhere in that.
Mentioned. Okay.
Meta-analysis study. Yeah.
Okay, so I'll take those questions. One is whether freezing and thawing is adding cost. Well, I definitely agree that especially in poor responders, people whom are expecting that you may transfer. Normal responders and hyper responders, definitely PPOS is excellent alternative, basically for the fact that most of the time normal responders and hyper responders we wouldn't transfer. We all now are going ahead with analog trigger and then freezing all and transferring at a later date. However, poor responder is one area I think wherein if you are contemplating a fresh transfer, ANTAC should still be your first choice. That's about the first question. The second question, and about the cost of the whole protocol, the systematic review did not say anything, is what I understand.
No, I
Is,
think that what we have to understand is in current scenario, all of us are doing more around 70 to 80% all free cycle.
yes,
So where
yes,
so it makes sense to maybe adopt these kind of protocols.
correct. Thank you,
I
Dr.
think this
Santosh. Thank you
protocol
for your
is
kind words.
protocol is brilliant for like donor cycles and for fertility preservation. I think for them, there's definitely no controversy.
Yes, totally agree on that.
And
Dr.
another
Vidyashree
thing is
Pujari has a
maybe
question. Yeah. Yeah, go ahead, Dr. Santosh.
no, I was really keen to know about, as you go ahead, about the clinical pregnancy rate, abortion rate, and all. As you said, it is initially you are finding it as far as the normal protocol. So it
Yes.
gives us, I think, more confidence to everyone to start using these kind of protocols probably.
Yes, yes. Yeah, for an overlook, it looks very similar between the two, but yeah, the calculations, Dr. Jayashree is still doing the calculations. I think possibly next journal club, I can put up that outcome as a continuation for this journal club.
Ma'am, can I ask a doubt, please? This is
Yes,
Dr.
please.
I'm Dr. Shaviz from Nova IVF in Mangalore. So my understanding, the PPOS protocol you've not been using much, but my understanding is basically if you use only recombinant FSH, probably because of the profound LN suppression caused by this medication like Meprate will affect the maturity of the oocytes and further development. So I think HMG would be a good choice. The other thing is also maybe if you could look into is there any differences between the oocyte morphology, like profound granulation of the oocytes, like minute details that will give us some more insight on whether it really affects the oocyte morphology and oocyte quality. Probably you could do a sub-analysis and like retrospectively go back and see the oocyte morphology, etc.
Thank you, Dr. Saviz. I'm glad that people are intently hearing this. Yes, I would like to give an answer for your question, or rather your suggestion. Basically, oocyte morphology is a very subjective term. So if you are trying to make out a difference between oocyte morphology for ANTAG and oocyte morphology for PPOS protocol, it's going to be very biased and also will differ from person to person who is handling the oocyte. Because we don't have a grading for oocyte morphology. It is a very subjective thing when people say, oh yeah, this is granulated. Oh yeah, there is debris in perivitelline space. So basically we have to take indirect measures, indirect indicators of oocyte morphology, which is nothing but blastulation rate, fertilization rate, cleavage rate. These are indirect parameters which show that the functioning of that particular oocyte is quite okay, or that particular cohort of oocytes is quite okay kind. And that's why we didn't try to dig that further.
Yes, ma'am. Thank you.
Thank you. Yeah. So the Dr. Vidyashree Pujari has put in a question: what was the trigger given in the thesis, and how do you decide? So most often we have always used, or not always, most often we have used decapeptyl trigger in almost 90% of the patients. If in case in the previous cycles people have not done well with decapeptyl trigger, is when we have added a dual trigger with the HCG also. What was the inclusion criteria?
I have one.
Yes, Dr. Santosh.
No, you take that question. After that, I'll ask.
So what was the inclusion criteria in the thesis? Dr. Jayashree, can you read out go back to the slide on inclusion criteria?
Give me 5-10 minutes.
It is like all women who are between.
Just move the slide back, I think.
Yes.
You have it.
Yes, here. All patients who are undergoing IVF fixed between the age of 20 and 40 years, ma'am.
Yeah.
So, ma'am, you did not categorize as like expected normoresponder, hyper, or poor, ma'am, in the inclusion criteria?
No, we did not categorize as this one.
So can we, that also subgroup analysis would be better.
See, across all groups, if things have been same, I doubt whether that will add, but yeah, we can take up that advice and divide them
and one
into
more, just as a practical doubt, ma'am, in case, how are you giving the Meprate tablet? They'll take it in the hospital itself, like
5
under
milligram?
supervision?
No. We just trust them.
By chance, only doubt in case if they miss a
only
tablet.
thing that we reiterate and we keep telling them very seriously is that if you don't take this properly, the whole cycle is going to be a waste. This is something that we
Okay.
dogmatically mention at the beginning of the cycle and make sure that they're taking, and 12-hour difference. That means morning 8 and 8 or
Is
morning
there
9
is there
and
any reason why you are giving 5 mg twice daily? Because I give
we took
10 mg once, ma'am.
we took can I say, we got inspired from the studies that we had seen. Most of the studies, Dr. Narmada can put a little more highlight on
Yes,
this.
ma'am.
She was-
2-3 articles before starting the PPOS cycle, 2-3 articles, recent articles we went through. Most of the articles it's given as 5 mg BD instead of 10 mg OD. So that's why we also started trying that.
Okay, there's a question from Dr. Varsha Patel. The question is, what if the patient misses MPA in between the cycle, 1 or 2 doses? Well, I wish that she does not miss, and I think we have to be optimistic in trying to, or diligent in trying to avoid it. But if God forbid that happens, I think MPA is a little long-acting drug. We could choose to go ahead and.
Somebody has to mute.
Yeah. So we can choose to go ahead and check the hormones, E2LH progesterone, see if there is any damage already done. If it is done, maybe I would add an antag along with the next separate tablet. I think that would be one of the options that we can do. If anybody else can think of anything else that can be done if somebody misses MPA. In our whole 80 patients, none of them missed MPA. Nobody came up with that problem. I think we can add an antag if in case the LH is already started rising or you see a progesterone rising, but we don't have to cancel the cycle. We can continue it is my suggestion.
Adding antag for just 1 dose, ma'am, or like we need to
Just one
continue
dose,
for
just, yeah. Just one dose. Yeah.
Okay.
Yeah. And maybe
Okay,
if you
I
want, you
have
can
one
check the hormones on that day and check the hormones again the next day so that there is no change in the suppression.
I have one question now.
Yeah. Yeah, Dr. Santosh.
Regarding the choice of progesterone. So if you read the literature, they say you can use dydrogesterone as well. You can use micronized progesterone. You can use medroxyprogesterone acetate. And I agree with that, that most of the studies, they are using medroxyprogesterone acetate. Probably that drives us to use it more. But all studies say that all of them are efficient. To my understanding, medroxyprogesterone acetate, that progesterone has some kind of other activity also. So why we are not using dydrogesterone and all those things if they are equally effective? Do you have any say? Because most of the studies like you have use Meprate only.
I have a feeling it could have been because of cost benefit. Dydrogesterone is an expensive drug. And it's more of a synthetic hormone than a natural progesterone. Maybe that fear is also there. And MPA is slightly longer acting. That might be the reason, but I'm not too sure exactly why MPA became very popular.
Maybe it is a longer acting. Even if they miss one tablet, nothing will happen.
Possibly, yes.
Yeah.
Yeah.
Okay, in
so
your
there are
study...
other questions here. Shall we just finish the questions here, Dr. Santosh?
Yeah.
There's one more. PPOS in normal and poor responders. What's your opinion? Well, poor responders, if in case you're planning for a fresh transfer, of course, PPOS should not be your choice. And most of the poor responders, I think I would still opine that fresh transfer will still give us a good pregnancy rate. I hope all the seniors here agree on that, because my experience has been really good with fresh transfers, especially when the number of oocytes are 5 or less, and if E2 is well within control, and if progesterone on the day of trigger is well within control, I would rather choose to go ahead with the fresh transfer. So poor responders, most often, if I'm considering fresh transfer, I would prefer not to do PPOS. In normal responders, we always aim for 10 to 15 oocytes when we are starting stimulation, even in normal responders. So 10 to 15 oocytes means no fresh transfer. So PPOS is a desirable choice for us in normal responders. Dr. Sumana here has asked for, can you please comment on the quality of the systematic review and its implications on the results? Well, I'm not so great at statistics. Dr. Sumana, are you here?
Yeah, I'm here.
Can you please throw a little light on that? I would really think that you would know more about this than us.
So basically, I think she can go to the PICO.
Which one, ma'am?
Participant, intervention, comparator, and outcome. Yeah, I think. Yeah. Yeah, so if we can see here, see now we have to be clear about what patients we're selecting. So here it's a very general random group. It just inclusion criteria is just participants suffering from infertility. So this is a whole varied group which includes patients with good prognosis, poor prognosis. So it can be normal responders, poor responders, hyper responders, and all these people will have a bearing on our clinical outcomes. So for us to have an idea about how accurate the results are, so we have to compare like versus like. So either they should have done a subgroup analysis with the type of responders. So otherwise, it's not okay to conclude that pregnancy rates are the same if you have included both PCOS as well as poor responders in the inclusion criteria. So that is one. Then
Right,
second thing,
yeah.
in type of intervention, see, again, you're comparing PPOS with a whole lot of different types of protocols. See, how can a GnRH antagonist protocol be similar to mild stimulation? Isn't it? So obviously, the study would have been better if they had just restricted themselves to maybe PPOS with only GnRH antagonist. So again, this is a big confounding element here. Then next. Yeah, so primary outcome obviously in IVF has to be live birth rate. So again, we have a mix of clinical pregnancy, live birth, and all that. Then next, secondary outcome. Secondary outcome, see, if we are talking about number of M2 oocytes, retrieved oocytes, so mild stimulation obviously will give you lesser number of oocytes compared to a PPOS or an antagonist protocol. So that should again have been excluded from from the studies that have been included. Then next, please. And as you rightly mentioned, the heterogeneity is extremely high. So I think the I-square was 80, 90% or something, right?
More than 70%.
Yeah, so we have to take all the
90%
results
is right.
with a pinch of salt. So definitely the quality of the systematic review will rate very low. And we have to really wait for a better, we have to look for a better systematic review to come to right conclusion. So this is just for learning for the, postgraduates. So it's not good to just look at the study question and the conclusions. So there's a lot that we have to see in between. Right. Okay. Thank you.
Right. Yeah. Thank you, Dr. Sumana. Excellent. That was. Yeah. I do understand in the ideal world, what you said should have been done. Yeah. So many times we want of, whatever studies are available, I think they try to do their best in it. But having said that, there are RCTs. I think there is enough scope. I think we'll wait for some more research that will come in this area. And the fact is that it is giving good amount of cycle suppression. So it is one of the option in your whole paraphernalia of all the things that you can do for a ovarian stimulation. So thank you so much, Dr. Sumana, for that. So the next question.
I think the message that we have to take from here is basically in our practice when we see a patient, and probably if they're not affordable to go in for like the anti in the more like a higher cost, this can be tried because we are getting pregnancies and we're getting embryos. So at the end of the day, looking at what the patient or individual couple can afford for a pregnancy,
Correct,
we can probably try this.
Yeah, so yeah, that is true. What you're saying is also very true, Dr. Shavis. There will be never a ideal and the best review, the best meta-analysis or the best RCT. We can always have a critical view towards things. But from overall, as you said, this is one of the options, especially for people who want to save cost. Gunashila Hospital is mentioning, did you find out embryo status in both groups? Yes, blastulation rate is what we considered as embryo status and utilization rate. Instead of taking grade A, grade B, grade C embryos, we thought that let's take it as utilization rate. That is, if the embryologist and the clinician thought that these embryos are usable, freezable, and transferable, that means that these embryos are good. In such way, we compared utilization rate between the two groups, and they were similar. Dr. Shubha, great discussion. Thank you, Dr. Shubha. Thank you. Thank you so much. Any other questions or comments? Dr. Santosh, you wanted to say something. I think last time I interrupted.
Santosh?
You're muted, Santosh.
Hello.
Yes, yeah.
So I think it was a wonderful discussion and wonderful experience as well for all of us. So all questions are done, or shall we conclude the session?
Yeah, I think we can. There are no further comments.
It was a
here.
great start for the.
Right. I thank Dr. Jayashree for putting in the hard work, doing such an elaborate in-depth analysis, not only on the systematic review and meta-analysis, but also taking the effort to go into the detail and nitty-gritties of doing the study. I thank Dr. Narmita for helping Dr. Jayashree out in making this presentation. I thank my colleagues from KISAR, Dr. Nivedita, Dr. Santosh, Dr. Lavanya is here, and all the office bearers of KISAR. I thank all the delegates who have come here. It shows that all of you are quite academically interested, and this gives us encouragement to do these programs more often. Thank you so much. Thank you so much. I really appreciate the time you spent on this. Thank you, guys.
So thank you so much, everyone. With all of your permission, can we end the session over here?
Yes, Dr. Sneha.
Yes,
Thank
Sneha.
you. Thank you so much.
Bye-bye.
Thank you.
Thank you. Thank you. Bye.